And have we got everyone tuned in on Zoom? Do you have good sound and can you see the screen okay before we jump in? Perfect. Okay. We've got a full house in person, and I think we've got a pretty full house on Zoom as well. So, welcome to the third session in the UCSF Innovator Seminar Series, which is a monthly series, and we'll talk a little bit about making sure that you stay on the mailing list, and we'll keep updating you. This is brought to you by the Innovator Enrichment Program within Innovation Ventures. And we'll give you a little bit of background on that first. And then after that, we're going to get into our exciting speakers. So we won't take much time, but we want to give lay of the land each time we start the series, because it's all about you knowing what resources you have and what fertile soil there is for you to become or to advance as a frontline innovator at UCSF. So this is just an example of some of the topics we're going to cover in this series. We're building a curriculum, an innovator curriculum with a certificate program, and this is the pilot for that. So all your feedback will actually inform how that curriculum develops. And that will also help with your career advancement as well as giving you skill sets and expertise in innovation. And so tonight I'll do a basic intro. You'll hear from some of my colleagues very briefly on what we do, and then we're going to move into the topic of the night, which we're really excited about. And I want to say that we have institutional support for innovation at UCSF. And that comes from as high up as our provost, but also from our chancellor. And this is Catherine Lucy, who many of you know. And she stated that UCSF's top priorities include inspiring, that means reaching out even to the pre-innovators, those who may not even know they want to be a frontline innovator. So inspiring, identifying, and investing in our frontline innovators who are translating their novel ideas into beneficial impact at scale for healthcare and life sciences. And so that really captures what we believe the fertile soil of UCSF for innovation is. And then also our Innovation Ventures leader, Dr. Peter Katsanis, who's in the audience with us tonight, is fully committed, says IV is fully committed to developing methods and programs for early identification and support of our frontline innovators and their impactful innovations. And so how do we do that within Innovation Ventures? First, we try to advance the slide. How do we guide your innovations from idea to impact? Talk a little bit about that, but mindful of the fact that we're not just building things, we're actually developing innovators as well as their innovations. But going all the way from idea discovery to discovery all the way across validation, disclosure, patent filing, and all the way to creating some way for this novel and helpful solution to scale up and out of the university. And that's the translation into the outside world. And we have many units. So one unit works really hard on what you've traditionally heard of as tech transfer, but we have 5 core units. So Office of Technology Management Advancement, you'll think of that as tech transfer. Office of Strategic Alliances, where we build big partnerships between outside partners and UCSF and create the hybrid vigor of doing that. And you've probably heard of many examples of that, including Genentech partnership, Pfizer, Roche, Lilly, and we have many in the pipeline, but many historically have been incredibly successful for us. So that also means it's an opportunity for you to develop as an innovator, not just in academia, but if you want to do internships or externships, we also help facilitate that. So you can find out innovation outside of UCSF. There's the Catalyst Invent Fund. You'll hear about that in just a minute. Our program, Innovator Enrichment, where the seminars are coming from, and the Entrepreneurship Program. And so what we'll do is just talk about each of those very, very briefly, starting with the global entrepreneurship. We want to keep telling you about things where the opportunities are open right now. So you could enroll for this. It's an international course online that's been taught for several years and developed by Stephanie Maris. And this is open enrollment right now. So go ahead and look online and I'll give you the link to that right here. But if you have any questions, you can always put in innovation at ucsf.edu, and that will get you to any of these programs that you want to hear about. So another one is the Catalyst Awards program. That's our internal accelerator at UCSF, and it's actually one of our leaders, Nate Prorock, is here, and he can give you more information on that. Nate, did you want to speak to this for just a second?
Hi, all. Yes, the Catalyst Awards, it's UCSF's Translational Accelerator, and I see several Catalyst awardees here in the room today, which is really exciting. So the Catalyst program not only provides seed funding for a lot of basic science or basic science translating to product and commercialization opportunities. But we provide industry expert mentorship. So not only are you getting, some funding, but you're also getting some really good insight from some seasoned entrepreneurs, seasoned innovators to really help turn these products, these ideas, into products. And so folks can apply for that award. A Catalyst Award via the RAP portal opens very soon, August 29th. And from there, you'll be hearing a lot more. The other thing that Catalyst does is we have an internship. So a lot of students, trainees, and learners, if you want to be more a part of the Catalyst program and learn what it takes to translate an idea into a product, you're encouraged to apply for that next summer.
We have a tripping hazard up here, which I feel bad about. I'm the director of skeletal health at UCSF, and my job is partly fracture prevention, but we'll see how this plays out. All right, thank you, Nate. And let's move on now to the Innovator Enrichment Program, which is the newest unit in Innovation Ventures. And this is really motivated by the fact that we want to go upstream on innovation, not just sit in Innovation Ventures and wait for disclosures to come in and react to them. We want to go way upstream, and we want to help inspire people who haven't yet been innovators, and also identify those who already are early stage or even serial frontline innovators or even entrepreneurs. And in our description, that means those are people who have decided to take their idea outside the university, go with it, and build a company out of it. Some of those entrepreneurs actually boomerang back into academia to solve the next problem as a serial innovator. But we really want to diversify this community. We've done quite a bit of homework on figuring out what is our community, what's the profile of our community of innovators at UCSF. And not surprisingly, it looks a lot like the tech innovation community outside and other universities where it's predominantly male, predominantly late stage in career or senior in career, most 25 years since their first publication. But we know there's a real appetite for a much more diverse community of people who want to be innovators and be involved in it and even start much earlier. So we want to create those opportunities and provide the education that's required, because you as scientists or as clinicians who want to be innovators, you don't really have a formal training program in that like you do in the sciences and the clinical skills that you get trained in. So we want to provide that education. So we want to make a rich innovator experience, environment, and ecosystem at UCSF. Just expand and enrich what's here already and make it more navigable for you. And also create a learning system. So we're checking ourselves, monitoring how we're doing, and making improvements. And part of that is your feedback. That's a really important part of it. I wanted to mention also that we're also doing more of a high-touch approach for our frontline innovators and offering innovator consultations. We're kicking this program off August 15th. You can use this email address that's on the slide here, innovatorenrichment@ucsf.edu, and you can schedule yourself. There'll be opportunities and time slots, and so it's pretty efficient that way. And then we'll act as air traffic controllers and help get you to your next step that you need to be. We're not the only source of innovation and innovation expertise and resources at UCSF. You're going to hear about a fantastic program tonight, the Center for Clinical Innovation, but there are almost 20 innovation initiatives at UCSF. It's just very hard for people to understand what do they all do, how do you get to them, how do you become a part of them. So we're building an innovation coalition, not a central governance, everyone still does their own thing, but it helps people be able to navigate and get to them, and we can amplify each other's work. So you'll hear more about those as we go through this series. We also have a wealth of experienced innovators who lead by example at UCSF and who are very accessible. And so you'll find, you'll come to us if you wish, and we'll help guide you to these people. And you'll just keep watching who's doing what in the many publications at UCSF. And most people are very, very accessible and want to help. So our seminar series, as I mentioned, is the third Tuesday of every month in the same time slot. Again, hybrid, but the in-person experience we've seen in the first two sessions, we had a workshop in the last one, but the networking that's occurred here has already helped people jump forward onto their path as innovators and move forward. So it's been exciting to see it function that way. So tonight we have two incredible speakers. I'm going to start by introducing the center, which is the Center for Clinical Innovation, where they're actually solving real problems for our healthcare system and healthcare delivery at large. A lot of the ideas that they come up with to help solve our problems are then ones that scale and help other institutions as well. And we're going to hear from Dr. Ralph Gonzales, who's the director of that center. He's also in leadership in CTSI. He's an internist by clinical training, so truly a frontline innovator, a clinician innovator. And he's also got a Master of Science in Public Health. So it's incredible resource to us here at UCSF. Many of you will have seen him in the COVID town halls, and you'll see that some of the solutions that really helped us navigate in the best way possible through the pandemic came out of their laboratory. And his colleague, Jan Yeager, has something that I'm kind of envious of, which is a Master's of Design. And I think this is fascinating. She has helped me on many of my projects, including one called the Precision Space Health, or the Health Sense Matrix for space, because we work in space research as well. But her work had really helped guide us. And then we turned that document over to NASA, and they're implementing parts of that in their innovation work now. So let's move on. Let's get to the topic at hand. I'm very excited now to introduce Dr. Ralph Gonzales.
Is this microphone working okay? Maybe I don't need a mic. Oh, here we go. Okay. Thank you for that kind introduction, and thanks for this turnout. I was told that with the Zoom option that we might not see too many people in the audience, but this is great. So I'm Ralph Gonzales. I think Einar wanted me to expand a little bit on my background. So I'm a general internist by training. I'm the Chief Innovation Officer for UCSF Health. But that wasn't sort of the job title I signed up with when I started at UCSF almost 30 years ago. So I did do my training here in medical school, and I did my residency here. And when I joined the faculty in 2001, I was primarily a clinical and translational researcher, working to help promote judicious antibiotic use and reduce the overuse of antibiotics, and doing this with large, NIH and AHRQ-funded trials across the country. And what I learned over those years was how difficult it was to change behavior and how difficult it was to influence practice. And for some of you in the clinical world, you know that they talk about it taking 15 to 20 years for any clinical innovations to impact practice, even when it's just a pure clinical trial with beta blockers in patients post-MI. And so with that challenge and frustration, what dawned on me during all that work was that the problem was that we were trying to influence these health systems from the outside in. And while we could influence them enough during the clinical trial to get them to change their behaviors, as soon as we left after the grant was funded and we published our papers, a lot of times that behavior would go back to the old baseline. And so I pivoted about 10 years ago and decided I wanted to take a more active role within our own health system, because all my research was being done across the country. I wasn't doing anything at UCSF. And so that led me to taking on a role as first the Associate Chair for Ambulatory Care Operations, which was not a role that my chair at that time, Talmadge King, who's now our dean, thought made sense to me for him, made sense to the department for me to be serving in that role, because I'm a researcher and I should be bringing in all these grants, and why am I going to, pay attention to care delivery? But I convinced him that, I think that, there is research to be had. It's more applied research. There's ways that we can use a more rigorous approach to how we improve care and at the same time spin out innovations along the way. And I'm going to talk a little bit about the eConsult program as one of those innovations that actually went to market and a third party picked up and licensed our work there. After that, I then became the Chief Innovation Officer as part of our 2015 strategic plan. We started the Center for Clinical Innovation, or the CIC, the Clinical Innovation Center. We got to hire Jan shortly thereafter, who's been a really key part of that work. And so what I'm going to share with you today is what is the landscape right now that we've created at UCSF Health to help promote innovation. What are some use cases and examples that you could borrow from? And hopefully give you some insights into how we can establish the right conditions for your innovations to be most successful. And as you're going to find, in the title of the talk, how purpose-driven engagement can yield positive results in practice, is that it's really a problem-solving approach. Now, some of you may have developed widgets or technology that are looking for problems to solve, and there's a role for that. That's okay. But what I'm going to be focusing on today is from the health system perspective. How do we problem solve in ways that allow innovations to emerge? And we're going to share with you a couple of those approaches. And then the second part here, in terms of yielding positive results in practice, is that the real impact we're looking for and striving for in all of our work is to impact patient care, patient outcomes. And so whether or not we monetize or take something to market is sort of the second tier goal, but it's not the first tier goal. And so that will emerge in some of the use cases that you see today. So that's us. And so the Clinical Innovation Center, like I said, this began about in 2015 to help UCSF Health in their strategic plan to help take us from this sort of 3-hospital, relatively small academic health system to what we are today, which is now a health system. And along that way, how do we increase access to our services to the people who need them the most? And how can innovation help do that? And so what the CIC was really designed to help do first was to help the UCSF Health to improve their service and performance across sort of a wider range of care delivery. But we also had this bipartite mission to also work with the campus side, the schools of medicine, dentistry, nursing, and pharmacy to research, monetize, and disseminate promising products that are emerging from our faculty and learners that work here. And so we really are serving a bridge function. The key outcomes that we measured in our relationship with health was how can we deliver the best care at the lower cost, and also at the same time recognize that a lot of our care delivery innovations need to also create an environment that makes UCSF Health the best place to work. And if you follow the literature on burnout, this is really a very high priority goal for UCSF Health right now, is to reduce physician burnout in ways that ensure that we keep attracting and retaining the best physicians here. Of course, on the campus side, we worked on developing research and training opportunities, and some of those you're going to see in the talk. Okay, so I want to draw sort of a distinction between what I mean by outside in versus inside out. And so on the left, I think most innovation centers, if you look across the US, innovation centers associated with hospitals and health systems tend to have an outside in approach. These are chief innovation officers who are very well connected and networked across the community of entrepreneurs, startups, and innovators, and they're trying to crowdsource and find the right innovations that they want to invest in, and they bring them into their health system, and they pilot test them, they might invest in the products, and then take them to market. And that's a very viable way to do things. The hit rate is extremely low. If you'll talk, we tried that model with the Center for Digital Health and Innovation, and they eventually found that it was not worth the squeeze. But it does work, and the reason it works is that those innovations coming into the health system understand product design extremely well. We don't, as clinicians, understand that too well, but they're set up for that. They understand the business model and they understand the technology. But the problem that many times happens is that they either fail or take a long time to get implemented into practice. And the reason that these examples like continuous monitoring devices, we've had continuous monitoring blood pressures out in the community for 20 years. We still have not found a good way to integrate those into our clinical practice. Patient engagement apps, there's thousands of them out there. Some of them have short lifetimes, some of them have longer lifetimes, but they have still not really changed practice in a large, meaningful way. But they will. I think that as they keep doing the cycles, and the reason that's happening though is that this is our pointer. They don't understand. they're not being designed to fit in with the health system that they're trying to influence. In part because they're coming in from the outside and they're not fully engaged in the problem solving and solution that should be happening from the ground up. And so that's what we set out to do with the inside out approach. And these are some examples of innovations that really gain traction and have become the standard of care now across the country. Checklists, that doesn't sound very innovative, does it? But it turns out that checklists in healthcare was innovative because every physician and surgeon wanted to be their own sort of boss and decide how they were doing things, and you had a lot of unstandardized care. And so Peter Provost in a large critical care consortium in Michigan showed that if you just use a simple checklist, you can reduce patient adverse events and errors in the hospital by 60, 70, 80%. So checklists, it doesn't sound exciting, or maybe it's hard to monetize that, but that was an innovation that had a huge impact in a very quick amount of time. E-consults is something that we developed. I'll talk about that on the next slide. And then video visits, that doesn't sound too exotic either. We've had the technology for a while. I put it up there in part because what really helped video visits take off was the COVID pandemic. And once we had a really strong use case from inside the health system that said, we now have a mandate to see patients and manage these patients who can't get in or shouldn't be coming into the health system because we're trying to socially isolate everyone. Our video visits that we had goals of increasing our video visits by 1% a year, from 3% to 4%. We were #1 in the country, or at least in the state, I should say, when we were tracking this, and then COVID hit the next year, and we went from 1% to like 70%. So if you talk about a catalyst for change, a disaster and a pandemic like COVID really helped this innovation take off. And now you see that we're not going back to zero. Now video visits are here to stay, and payers are paying for them, and a lot of important things are happening. But we were promoting this long before COVID, but had a hard time getting traction. But the key here are what I'm listing here: infrastructure, work environment, organizational culture, and then the networks of the people that can really tell you whether something's going to succeed or fail. So these are the 3 examples of work that we did at the center, with the e-consult probably being the earliest and the one that has had the strongest traction. So e-consults are common now. Everybody's using them, but UCSF Health, as well as ZSFG, were some of the early developers of e-consults, and they are now standard practice. And like I said, the products that we developed here, we also, through Innovation Ventures, thank you, allowed us to find a third-party company that was interested in licensing our protocols because there was IP in there. And then they now help other systems use our protocols to deliver electronic referrals and e-consults. The integrated spine service. So this is a new way of managing patients with back pain who aren't getting better in primary care. And what's innovative about it is that they brought together an orthopedist and a physical therapist, and you're doing joint visits at the same time. So you're not seeing the PT separately from the spine or the back specialist. It sounds kind of simple, but this took a lot of elbow grease to get off the ground. But now it's a thriving and a very successful clinic. The third example here was delirium reduction, which the innovation here is a delirium screening algorithm that one of our faculty had developed and validated. And they were able to put into practice and show that they could reduce the intensity and the frequency of delirium by identifying people at risk for delirium and doing extra things to prevent delirium in those patients. And there's a toolkit that goes along with this it's a very large program that I won't go into all the details of. But again, that's an example of something that could be monetized or disseminated to other health systems because of the nature of the toolkit that was developed. And so what I want to bring, the point I want to make about these innovations is that we didn't start out thinking we were going to design an e-consult service. And we didn't come out start out thinking we were going to design a new delirium screening tool. These were the problems on the left that we were trying to solve when we started this engagement, and then the innovations emerged on the outside. So the problem here that people recognize that patients with chronic back pain in primary care are a real challenge, because the system for where you refer them to and how do you get success with those patients was very challenging. And so the system goal to tackle this problem was to improve the patient experience and outcomes with chronic low back pain. And we got the right people together to develop this integrated spine service clinic with a physiatrist, PT, and the Orthopedic Institute. And we got agreements between the two departments, PT and orthopedics, to figure out the proper way to manage the facility fees and the billing, because that, of course, was a huge issue. As it relates to delirium, the problem we were trying to solve back then was the fact that our emergency department was overflowing with patients in gurneys waiting to get a bed upstairs. That was the problem we were trying to solve. And the fact that patients who have tertiary or quaternary reasons for transfer, so you're out in a community hospital, you have an aneurysm, you need to come to UCSF. We have the best neurosurgeons to fix that. But they're getting denied because the ED is full of patients that are overflowing, and we don't have any beds in the hospital. And so what we were looking to was, how do we help increase the number of patients we can see in the hospital? And as part of that, how can we reduce the length of stay safely for patients who are staying too long or might have adverse events that are leading them to stay longer than they would have been ordinarily necessary? When you look at that data, so analytics is a key part of this, we find that 40% of patients that get admitted to the hospital have an episode of delirium. I mean, it's shocking to see it's that many people. And we found these faculty that were developing new ways to screen and prevent delirium. So we brought these groups together, and the delirium prediction tools and toolkit emerged out of that work. The last one with the e-consult program, again, that was one that we spearheaded, not thinking that we were going to develop e-consults. We had never even thought of the concept. What we were trying to fix here was that there were very long wait times to see a specialist. 5, 6, 7 weeks was common just 6 or 8 years ago. We've done dramatic improvements in that now, partly because of the way we've changed the consults. But this was, again, about ways to increase specialty care capacity, focusing on what the patient's needs are and what the community needs are. And then because we bring in this, we bring in this problem-solving approach that we're going to share with you, and people with multiple perspectives, this multidisciplinary team, we come up with these new ideas and innovations come out. And as a result, they have a much higher likelihood of traction and sustainability. So the first approach I was mentioning, the problem-solving approach, you're going to see more details of this in the use case that Jan's going to show you. But this is just to give you an introduction, which is this comes from the service design literature. And basically, you don't take for granted that you understand the problem when you're coming in to tackle something that's signaling the health system. And so it has two key phases. The first is to make sure that you're solving the right problem. The problem you think you're solving may turn out to be due to or manifesting of something that's much larger than that or different than that. And then once you decide you're solving the right problem, then you need to solve the problem right. And that's where the design thinking really comes into play. The second key approach that we use consistently across all the projects we work on is a behavior change approach. And in this one, we're using a model called the precede-proceed model that was developed by Larry Green and Kreuter 30 years ago in public health. I sort of tapped into this model in the 2000s because it's a behavior change model to help figure out how can we change the prescribing behavior of physicians when they're giving antibiotics that aren't indicated or necessary for common colds and bronchitis. And it's fascinating because once you apply this model, you realize that it's not just knowledge. I mean, a lot of the time we think that the way that you can improve practice and improve outcomes is just to give the doctors the practice guideline or the knowledge they need to do the right thing. But what you learn is that the way that physicians practice is influenced by a whole host of other things besides just the knowledge. And so with antibiotics, it turns out that patient expectations and demands, whether they were real or perceived, was a huge driver. The volume, how many patients they're seeing per hour. In primary care, they're seeing 3 or 4 patients in an hour. You don't have enough time to explain to patients why they don't need antibiotics, because if you just write them the prescription, they're in and they're out, and no one's mad at you. It's like, just having one upset patient kind of ruins your day. And so, these are the things you uncover once you start to dig underneath. But in terms of the pre-seed model, don't look at the phases, just look at this part, because this is the key piece, which is that it recognizes that quality of life and health are the result of behaviors, genetics, and environment. Those are the key drivers. And that you can distill down most innovations and improvements in practice and care delivery involve some type of behavior. And if you look at things through this new lens, you'll find that this applies to lots of things. So in the delirium program, the behavior was, well, we developed this new prediction tool, but the nurses have to use it. So how do you get nurses to use it on every patient? And so what's the approach to that? Or if it's a new integrated spine service clinic, how do you get patients to accept a referral to see and participate in this new model of care? Yeah.
Before and after trial or a comparison, because you may have obviously be very optimistic about what you're implementing, but you don't know for sure if it's actually going to improve things. So
yeah, no, that's an excellent point. And that's part of the way you do the evaluation here. You not only look to see whether the outcomes have changed. So with the spine clinic, for example, did patient expectations change? Did their satisfaction change? Did their pain get better? And so most of the time when we do these evaluations, we're looking at both the hard outcomes, but we're also looking at these process measures to see if the theory that we put into place as to why it's going to change behavior was actually how it worked. So that predisposing factors, for example, represent knowledge, attitudes, motivation. So people can't change their behavior if they don't want to change. We learned that with smoking cessation a long time ago. That for the longest time we would do all this education with patients about why they needed to stop smoking and how they could do it, and then they came back and realized that if they're not ready to change, you don't need to waste your time on anything else. So you wait till they're ready to change. And so if you have an intervention that tries to increase their likelihood of wanting to quit smoking, then you should be able to measure that in a survey. And so we tend to do process evaluations that measure each of these things. But the point of this slide then again was that when we look at behaviors, when we look at these, when we go into the problem-solving process and we identify the key behaviors that we want to influence to improve the problem, you can pretty much always require predisposing, enabling, and reinforcing factors as contributing to that behavior. And I'll show you this in another slide, but what we know is that if you only work on one of these, if you just give people knowledge, that can help some, but many times there's other factors contributing to the reasons why they maintain that behavior. Enabling factors have to do with whether or not it's easy to do, whether or not they have access to the resources to do the behavior. In fact, a lot of what we do in the EMR is about enabling the right behavior, because people may already have good knowledge about how to manage something, but if there's too many clicks you have to go through, or if you just didn't think about it, then it may not happen. What we do in the EMR is we put in these tools, these decision support tools, that make it almost impossible not to do the right thing or do the right behavior. That's an enabling strategy. And then the reinforcing strategies are really those that make the individual have positive experience with the behavior, so that they get feedback, positive feedback. They can get audit reports, and they can. A lot of health systems, what they'll do is they'll publish your performance, like your antibiotic prescription rates or your e-consult rate or your delirium screening rate. And they'll let you compare you with your peers. That's an example of reinforcing a reinforcing strategy to improving behavior, because nobody likes to be at the bottom of the curve. We all want to be at the top of the curve. And you can do that in ways that isn't punitive. All right, so I'm not going to spend too much more time on this. Let's keep going. So I talked about the approaches. So those approaches are things that we do with all engagements when we're looking at problem solving, with an eye towards innovation. But then from the health system level, at a meta level, we also think about platforms. And I think I use the term platform to imply or to refer to the infrastructure that we can put into place at UCSF Health to ensure that there's consistency in the approach and to allow the people and the partnerships to come together in a meaningful way. And so the three platforms I'm going to mention today are the Caring Wisely program, which you all will have, would be eligible for when at the next call for proposals, the UCSF Health Strategic Innovation Collab, and then I put up here Hospital Incident Command System, because this is what happened during COVID, and it was really illuminating how fast you can accelerate innovation in a disaster. And so for those innovators out there, the next disaster you see, that's actually a prime time place to get yourself inserted if you have something that's going to match up with that disaster. I thought I was going to show you a slide here, but I didn't. Oh, I know. I wanted to frame the platforms in one other way, which is the intensity versus the scaling, because each of these platforms actually have a different target audience in terms of who they're trying to, whose needs they're trying to meet and who they're trying to partner with, and how that fits within our clinical microsystem. So this is Healthcare System Org 101. So there's something called active daily management, which is part of a lean organization. So these are the huddles that happen every day on the hospital wards or in clinic. And in a lean organization like ours, they should be talking about how the previous day went. Were there any flub ups, or were there any miscommunications or patient errors or things that happened? And then they fix those. And so it's a very horizontal. I put a horizontal arrow here because it's not top down or bottom up. It's just everybody there at that time making small little tests of change and improvements that they see every day. At the next level is the small scale improvement. So that's the example of that is the Caring Wisely program. And so this is a platform that allows us to support frontline project teams who have good ideas. So any of you could represent a project team that has a good idea. And so now we have this Caring Wisely program that lets you submit your ideas, lets you workshop that with the community as well as with the Caring Wisely team. And then this really supports bottom-up improvement, but it tends to be focused in 1 or 2 units. It's not like enterprise scale, because that's the next example, which is the large-scale improvement. So the Strategic Innovation Collab that we've started is a way in which we meet with the executive leaders across UCSF Health and identify from them what are your top priority areas. And if we bring the CIC, the Clinical Innovation Center, together with the Department of Quality and the Continuous Improvement Department, how can we help implement something that's going to roll out system-wide, enterprise-wide? So this is a top-down approach. And this is also an effective way to make change. And the sepsis collab example that Jan's going to share with you is an example of that. And then the last one, here is the crisis management, which is kind of both at the same time. And yeah, so this is an org chart of what happens with a hospital incident command system. And this is what we applied here at UCSF. So the only other time that I operated with HICS with this system was during the large nursing strike. And so you can imagine when all the nurses go on strike and stop working, we have some replacements, but we now have to look across the whole enterprise and figure out how can we still deliver patient care safely. And it involves canceling surgeries, it involves moving people around. It's a big, big deal. With COVID, it was that on steroids because we had our employees getting sick. We had our patients who were really, really sick, especially in the first phases. We had these, public health orders and mandates coming in telling us that we had to start doing something a certain way right away. We had a whole new testing infrastructure we had to put into place, a whole new vaccination program. And so this type of organizational structure or platform, I'll put out there was a tremendous engine for innovation, because every day or every other day for the first year, the leaders of the entire health system are meeting in a room for an hour and talking about, what's the current state, where are the problem areas, what do we need to fix, and you make a decision. You have authority, you have resources, you have everybody in the room. And so suddenly you don't have like 3 different meetings scheduled 4 weeks apart with people who aren't communicating. You have
And the other point that we've gone over and over is that innovation is in personnel, process, and technology. And a lot of people think of it just as the latter.
Those are great points. So to finish the Mexico during the flu H1N1 outbreak, what I was most impressed with, number one, they shut down the whole country within the first week. Like, I didn't expect that to happen. But when you tuned in on the news every night at 5 o'clock, you would see every minister of every agency in the federal government on TV. They had a big table like this: education, finance, schools, et cetera, down the whole line. And they were there representing their sector and telling you what they were doing next to help combat this pandemic. And so this is the same idea, but within a health system. The types of people you have under the operations section chief, so you have all the chief medical officers and operating officers, the chief nursing officers. You have people from supply chain. You have people from finance. We wrote a lot of checks, like huge checks, with just the faith that we were going to get some of that back. But you have one incident commander. It was Kim Skur, and that person makes the final decision. So you never leave the meeting without a decision being made. Sometimes you may get some more information and come back. But again, what was amazing was we innovated 4 or 5 different products that probably are still primed to go to market if somebody wants to pick up on it. Some of them we've sent to Innovation Ventures. So I have a slide deck on what we did or what kind of came out of that, but I saved it for the end because I want to make sure we have time. So I might come back to it. But let me tell you about Caring Wisely, because this is a program that we've set up to help partner with frontline teams who have good ideas about, in this case, ways to reduce our healthcare costs. So this Caring Wisely program was started about 10 years ago with some seed funding from the Center for Healthcare Value, who got a large donation from a donor who was really concerned about the way that healthcare costs were continuing to go up 2-3 times the rate of inflation. It's so much higher GDP in our country versus other countries. And then when you look at UCSF, our costs, we were at the 99th percentile. That's not where you want to be in healthcare costs. And so we knew that we had a problem. We also rationalized that if we put into place interventions to reduce the healthcare costs, that we could do that in a way that would save dollars for UCSF Health and pay for the program. And so this is a way we could tap into our frontline innovators to help do a good thing for UCSF Health, good thing for society, and good thing for our patients. The important part of this was that you had to also measure and make sure that quality was maintained or increased with whatever it is you were doing. We didn't want to reduce costs and then reduce our quality. So we recognize that the most successful interventions are from engaged frontlines. And I want to make a shout out to this team because this team is really they're a real critical piece of this, because in contrast to a grant program where you get money and then sort of a year later you give a report, in this is more like a marriage because you're going to be partnering with the Caring Wisely team who are going to help you all along the way to design, implement, evaluate, and refine your program. And that actually is a nice marriage because a lot of these project teams, people have full-time jobs. They're not getting a whole lot of dollars to buy out their time. They have day jobs, but they're passionate about their ideas, and this is a way we can support that. So Kat Lau is a hospital medicine doctor who's been the medical director the last 8 years, program designer, service designer. Jan, you'll hear from her. We have an implementation science lead who helps implement these behavior change theories with the project team and also develops a logic model and helps with the evaluation. We have the value improvement on the measurement side by Brandon Scott, who's also a physician. And then we have these other roles as well. Oh, but let me just say one thing about Karina. So Karina Zigarakis, resident, neurosurgery resident during her 5th year. She has to do research. She applies, has a great idea for how to reduce surgical costs in the OR, because what she noticed in neurosurgery is that it's just the Wild West. People use whatever they want. You look at the trays, half of them are not even opened, or they're semi-opened and they throw them away. There's just huge amounts of opportunity to reduce waste and cost. And so she proposed a program. We teamed up together, and I think she saved $6 million that year for UCSF Health. And a lot of that led to changes in the preference cards that people used. And one of her innovations was basically borrowing from Amazon. I think she borrowed it from Amazon. But basically, when it came time to order your instruments for that particular case, she would give them a list of low-cost alternatives for certain items on their list. And so like the hemostat stuff that people use in spine, who knew that, you use a lot of it, it may be $10 per unit cost, and you might use 100 units or 1,000 units for every case, but there's actually a $2 version that's just as good. And so, people were willing to still retain control of their cases, but they at least were given some information in real time so that they could make good decisions. So the Caring Wisely program, the objectives again overall are to crowdsource opportunity areas from you, the front lines, to create a collaboratory between the frontline teams, the implementation scientists, and the delivery system leaders, and to achieve a positive return on investment. So every project that gets submitted has to have a pretty good financial estimate of at least an ROI of $250,000 or greater, or savings of $250,000 or greater. And so the way this plays out is that there'll be a call for proposals that goes out, and there'll be a 1-month online campaign to solicit the ideas. The best ones get invited back to develop full proposals, and those get workshopped over a 2-month period with the Caring Wisely team and some other key stakeholders. And it's along this line that you start to engage. One of the key things you're going to hear from today is the importance of stakeholder engagement. The only way these projects succeed is that you have the executive leadership and the delivery system, the clinical operations leaders working with you. And if you don't have them involved, then it's a lot harder road to follow. And so that's the stakeholder roles I'm showing here. The project team, Caring Wisely team over here does a lot of that work. But then the executive steering committee, so we have, again, the CMOs, the CFOs, the CMIOs, we have a team that selects the final winners. So now they're kind of like putting their nickel down. Okay, I think this is a good project. I'm going to fund that project. So then I come back and say, well, Apex, they're saying they don't have enough resources to do the build that is proposed in that project. So things start to work once you have that commitment. And because now they're among their peers, they now have to explain, well, why did you select the project if your department's not going to cover the resources that are needed for it? So they do a lot of barrier removal, but they also have other resources that they bring to play. And then the final piece on the stakeholders is not to forget the patients, staff, and learners. And so that's the service design approach, where we really engage a lot with the people to understand the user experience, the pain points, and the human factors to develop the best solution. And part of that solution may be some innovations that come out of it. So analytics is a key piece. So when you're identifying opportunities, we use data. We like to have a data-driven approach. This also serves in the evaluation, because if you're going to make a change, then you should see this improve. So this is an example of hotspotting, if you've heard of that term. But the idea is to look for areas of waste, of unwanted variation, or unexplained variation, to identify places that you can make improvements. And in this project that came to Caring Wisely in 2012, UCSF Health had one of the highest rates of blood transfusion across the US. And how do you know that? You can just go on to, we have dashboards, Vizient, that compares us with all the other academic health systems. And you can look up anything you do and compare it to the other 200 academic health systems. And so we looked up blood, and lo and behold, we were at a very high, which meant we probably had some room to improve. And so when we went to the data, we developed this sort of analysis where first we were just wondering who's ordering all this blood. And so the size of each box represents the size of that domain. So hospital medicine was responsible for this big chunk, and that's relative to all the other chunks. Malignant hematology, because that's where people with bleeding problems and cancer, they often need a lot of blood, liver transplant, et cetera. But then within each department or service line, you have a smaller box. Each of those smaller boxes represents a different physician who ordered the blood. And so you have some physicians who order a lot of blood, and you have some that order very little. Notice over here, malignant heme, you don't see much. You see a lot here. You still have some small ones here. But then the third dimension that's represented on this slide, and Alvin Rajkumar gets all the credit for this, is the shade that you see here represents the hemoglobin level, or how anemic they were when you ordered the blood. So what we were trying to put into place was a program that would get people to use don't give blood until they're more anemic. So white, which looks more anemic, is better than the dark red, which means they have a higher hemoglobin. So you can look at this and say, well, at malignant heme, everyone's transfusing it at these very high levels. Well, it turns out that they have a standard order set that actually automatically orders blood every time the hemoglobin gets to a level. So it turns out that was where we had huge success, because we went to that service and said, these are the new guidelines. Don't you think you want to get in line with that guideline and think about reducing it? And there was some hemming and hawing, and to the point about evidence, when we implemented this in malignant heme, we also put into place some patient-centered outcome measures to make sure that it was safe for those patients. So they weren't staying longer, they weren't having poor outcomes, and that allowed them to continue to do it. And so when we did this evaluation, we reduced the blood transfusion by 30%. And that was also a huge savings, because blood's not cheap. And then I told you I'd come back to theory-based intervention design, but the way we make this as simple as possible with our project teams is to encourage them that in every intervention you implement, once you've identified that target, that behavior change target, is to have some component of your intervention should make sure that the person wants to change. That's their predisposing factors. They need the knowledge, the attitudes, the motivation. It should be easy to change. You should make it, I mean, the best intervention is just to take that person out of the equation and just make it happen automatically. That's not always possible, but facilitation, automation, integration are ways within the EMR and other places that you can help make it really easy for them to do the right thing. And then the reinforcing factors means that those individuals need to like the change. And so getting rewards is one way, getting audit and feedback, and then having opinion leaders or your department chair or division chief recognizing that your performance has gotten better or that you're implementing the behavior you're trying to change is working. And so we use this over and over and over again in each of these projects, and it's really been a time-tested model to use. This just shows the outcomes in a report she gave in FY22, but you can see here the direct cost savings. Our goal was at least 750, so in every year except FY16, you can see that we met our goal. In many years, exceeding that by 3 or 4 or 5x. Some of those project teams have submitted papers and have been publishing their work. And then some of these, we hope that we're also training and coaching people on how to apply this to other projects that may not be Caring Wisely projects, but make that part of their standard way of doing things. The last thing I'll say here is about the second platform, which is UCSF Health Strategic Innovation. And so whereas the Caring Wisely program focuses on project teams, usually within 1 or 2 units, the Strategic Innovation Collab is really looking at the whole enterprise when it's trying to design its problem solving and intervention. And so the Clinical Innovation Center, partnering with quality and safety and continuous improvement, is really helping to wrangle and bring together all these other important function departments, business units, and of course the patients, providers, and staff to help to design and develop what it is that they're doing. Okay, so I've come to the use case, but I want to stop because I gave you the landscape overview. I gave you the approaches that we use and some of the platforms. And then Jan's going to give you a more in-depth look at how we've been doing this with sepsis. This is live stuff. This is stuff we're doing right now. But do people have questions or comments on anything that I've talked about so far? Yeah.
Caring Wisely, you're looking for an ROI of like 250 or greater, and then you're throwing cost savings of like 700K to like 2 million for depending on the year. We'd love to hear a bit about like, is that the same in terms of how leadership might look in terms of putting their, is this like specifically to Caring Wisely, or is this a really like also like a financial metric that, the people who could change the barriers for that, and how may that be different for UCSF Health Strategic Innovation Collab? Do they have a different metric on how much they expect for?
Yeah, for the collab, it's not focused on cost reduction. So collab, like sepsis, you're going to see, we care about outcomes. So that's what we're focusing on. But with Caring Wisely and with other cost reduction interventions, I think 250 to 500 kind of is a ballpark for, like, when you think about labor and resources and things you have to galvanize that, for the people who understand the finances, which I don't, they see that as being worthwhile. In terms of sustainability, though, we count it for 2 years and we don't keep counting. But a lot of times, if you've done this properly, you change the budget, you change the new set point, so you realize those savings going forward. Yeah.
I have a question about. Although we like that delirium care, example, surgery, and although we like develop some tool that high sensitivity and specificity, I wonder about the prevalence in the clinical setting. I wonder like there should be some limitations according to the prevalence. If the prevalence is low, the predictive value, positive predictive value should be low, and in the clinical setting, like there should be some challenges like for implementing that according to the what kinds of actions we could choose to do after finding out that there is positivity according to the tool, but the real probability of that delivery would be low, but hospital should invest make some decisions. Yeah.
No, you're right there. I think just to reframe what you're saying, I think what you're talking about is that the prevalence of the condition that you're trying to screen for has a big impact in terms of your false positive and your false negative rate. So that if you have a low prevalence condition and you put in a screening tool, even if it captures 90%, because it's low prevalence, it still may be, a lot of the people it's calling positive may be actual negative. So it'll be a false error or false assignment. And that's part of why I think we were in good shape with delirium, because the prevalence was so high. And what we found is that we didn't really eliminate, or we didn't see as much of a reduction in the rate of delirium. What we saw was a reduction in the intensity of the delirium and the duration of the delirium. And so we developed this metric called delirium days. And so that's what we were able to track and show that it went down. But if you actually look at the number of patients getting deliriums, that didn't seem like it shifted as much. But you're right about the performance characteristics. And this is what you're going to find out in the sepsis use case, that the performance of the new machine learning algorithm is so much better than what's happening right now that it's going to make life a lot better for people. Because right now they don't trust the alert because there's so many false positives. I know.
Yeah. So as we transition to Jan, I'll just make a couple remarks. First of all, what you heard tonight was a lot about innovation process, et cetera, not just building a device or small molecule or drug discovery, but the principles still apply. So try in your own mind to think about the innovation you're working on, how you can apply some of these principles. Also, the point about frontline innovation, not only do we know the problems, but we actually do a deep analysis on the problem instead of just reading a headline in the New York Times and just saying, oh, well, that's something we can work on. Really, the root cause analysis and the deep evidence-based exploration of what the problem is, that matters. And the final point on frontline innovation is we have to swim in our own soup, meaning we really care whether these things work or not because we're going to be using them ourselves. And as we switch to Jan, I wanted to highlight, in case as you leave the room, make sure you know that in the midst here are seasoned innovators, including Dr. Alexander Lin, who's sitting right here. He's a pediatric plastic surgeon, co-director of the Center for Advanced 3D+ Technologies, and has some of his own inventions, but he's also doing surgery and working in clinic every day. So he really cares that these things matter. But just wanted to highlight, we have good resources all around us here. Thank you, Jan.
Excuse me. So this collab came together as a directive from adult services to look into sepsis. Because even though we had very good sepsis numbers at UCSF, hospital-acquired sepsis was something that was a little opaque and we didn't truly understand. And there was elevated incidences of that, which caused our team to come together. So we, as Ralph mentioned, excuse me, are part of this group with continuous improvement, the Clinical Innovation Center and Quality. And we were brought together to help some of our partners who are already working in this area to kind of amp up the work that they were doing. And that's what brought us to help them over the course of this past year and a half. So sepsis, as Ralph mentioned, is the most common hospital-acquired infection and the costliest complication for hospitals. And about 1/5 of the cases are hospital-acquired, resulting in more than 100 deaths per year at UCSF. There have been other efforts to improve sepsis outcomes, but these were largely sort of case by case and mostly community acquired, which means they happened out in the community and then they came to UCSF through the emergency department primarily. And we really didn't have a system level understanding of hospital acquired sepsis. So that's why we came together to better understand that. So bringing back the service design model, as Ralph said, we do engage everybody in the process, and this is an inherent characteristic of service design, is to bring people in who are actually going to be using and have the best knowledge about what's happening in the setting in which we are operating. So this is just an example of the people that we talked to and engaged with in developing the prototypes, and who we will continue to engage with as we implement the interventions. We also touch base with our executive sponsors across the entire thing. We use them as sounding boards to make sure that we're still working towards the right goals and seeking their guidance when we run into any kind of stumbling blocks, like Ralph was mentioning with the AI group that we're trying to work with and reprioritizing within their pipeline. So we use a combination of methods when we're in the discovery phase of qualitative research. We do observations. I mean, we're really down there shadowing nurses, talking to nurses and physicians, and also looking at how other institutions are managing this this particular problem, so that we get a very good landscape understanding of what's happening. We also combine that with data analytics, and we use a number of mechanisms and databases to get that understanding for refining and confirming what we're finding through our qualitative research. A typical outcome from the qualitative is what we call a current state map, and this is basically sort of a journey map of a patient moving through a hospital stay, if you will. And in this instance, it's like what happens when a patient gets a BPA, which is an alert that says, their vitals have gone out of whack and that, they could be potentially septic. And these are all the encounters and interactions that occur between nurses and physicians across that. And then on the bottom there is the sort of what we call pain points, which are all the disconnects that happen across all those interactions. So some of the things that we found were there really pretty significant communication breakdowns, particularly during transfers when patients may be moving from one unit to another. The BPAs, which I mentioned, are best practice alerts, are these little pop-up windows that when you open up a patient chart, if you're not clinically involved, that will tell you that you need to pay attention to this. Providers aren't using the sepsis order set. And everybody understands some piece of the bigger picture, but nobody really has a full understanding holistically of what a sepsis pathway looks like. We also learned that through the data analytics that people were canceling the BPAs without taking any action between 50 and 85% of the time. So just ignoring it was such a burden on their workload and their current work situation that they would just dismiss it. So we found that, combining the human factors and system factors would give us some direction on what we needed to do. We had to pay attention to how people are currently practicing, what their pathway was, their particular workflow, how they understood information, how trustworthy that information was for them. On the system side, we looked at things like the roles. People didn't have a full understanding of their role within the sepsis pathway. They didn't feel like they had accountability in some cases. Some units have very low incidences of sepsis, and in that case, they're not necessarily aware or have the training to understand how to manage it. So our solution to this was two parts. One, we wanted to develop a better signal for indicating that a patient was septic. And part of that was to simplify some of the actions that were taken. And the second part is to develop a machine learning model that will be more of a predictive tool that a patient is likely to become septic. And then as part of that, developing a conditional layer so that there's less redundancy in when this alert pops up. The other part was a better management system, and that included a clinical summary that's a part of the electronic health record that gives sort of a little snapshot of exactly what's going on with that patient related specifically to sepsis. And then we redesigned the order set. And overlaying what Ralph was talking about earlier with enabling factors, that these are all designed to support clinical decision making and to drive action. There wasn't any predisposing as part of this because everybody was aware that these signals weren't working. And they also were aware very much that, we had a problem with incidences of sepsis. So, significant death rate that motivated people to want to do something. So of course, when we do the design part, it's very typical that we use an iterative process for developing, and this is showing all the individuals that we talked with across several iterations of this BPA interface that we designed. And part of it was to understand how did it fit within their existing workflow, looked at nomenclature, like people's interpretation of words was really interesting to uncover. And also their preferences for information. Some, let's say, earlier career physicians preferred to have more information to help them make that decision, and later stage physicians wanted less. Just give me the facts, more or less. And how they interpreted the interface schema with what language and also the layout and everything was also important. And understanding their clinical context. Where am I with my patient care? I might be in their patient chart ordering some medication and this thing pops up. It's very distracting, takes me out of the flow that I'm in. And how do we understand how to avoid that as much as possible? So with the activation, we ended up with the nursing alert, we reduced the number of clicks for her to get for a nurse to be able to get to lactate order. And for the physicians, we reduced the alert intention ambiguity. So people were like just dismissing it without saying, why am I dismissing it, even though they had a very clear reason. Oftentimes they already were aware. So we added a button in there for sepsis treatment is already in progress. So just giving more intentional responses for why I'm removing this. We also added time frames underneath that. So, if I'm going to sepsis treatment is already in progress, I'm probably going to be able to dismiss that for 72 to 96 hours. And there's a specific time frame associated with each of those buttons. On the management side, we developed this clinical summary that gives you, here it's a little bit small, but there's on the top, the red, yellow, and then the green part underneath are different aspects of the order that you have to do certain things, and it tells you whether or not you've completed it or you still need to complete it or if it's in progress. There's also at the bottom, a little snapshot of the vital signs and antibiotic and culture trends and other information related to the sepsis treatment that I see all in one view, so I don't have to pull together from many different areas. Similarly, with management, we redesigned the order set to support clinical decision-making with improving the order efficiency by bringing together, again, like 10 different separate orders into one place, improving the navigation, reducing redundant information and unnecessary testing and orders. So this is an example of what we're doing in phase 2, which is building this algorithm that will pop up on the BPA that gives you a indication of the likelihood of a person having sepsis or becoming septic within a 24-hour period based on about 200 plus different factors. And that's it. Back to Ralph.
And just to say a couple more things about the machine learning algorithm. So that was developed with our data scientists who first started with the de-identified UC-wide clinical data set and was able to bring in all the sepsis cases across all the UCs for like I don't know, 5 years. And so that's how he developed the initial model. And then we did some validation using some of the definitions of sepsis from UCSF. But ultimately, to get anything into our system, they have to prospectively validate that model. Almost always, prospective validation of the models perform less well than what because when you design it on a data set, it's describing that data set, but it may not fully represent all the different types of patients. So that's the stage we're in right now with that. But what was really cool about how the engagement and the feedback we got led to the way that we're communicating the results of that algorithm or that machine learning tool is that they're representing the probability on a linear scale. So before the sepsis alert, we just say you have a high likelihood of having sepsis, and that's it. And it's like, well, the last 5 times I saw this, I didn't see sepsis. Like, I don't really believe this thing anymore. And part of that just because it was a poor tool. But with this one, we're actually showing the percent probability that the model is predicting they have sepsis, so that they'll have more faith in it, because the 90% should almost always be positive. And if it's 50%, maybe, you'll take your chances. Yeah.
But I guess I'm curious is when you analyzed these sepsis cases, like were the failures because of like sepsis wasn't being detected early enough, or was it due to other breakdown in care? Because the only thing that a machine learning model, which I have some thoughts about, but the only thing that that's going to potentially help you with is maybe early detection, maybe. If your failure points are all throughout like the rest of the process, that's not going to do anything. So is that what was happening?
No, the failure is mostly the tool is very sensitive, the one they use now. And so it's not missing that many. The problem is that 90% of the ones that it says think about sepsis don't have sepsis. So they don't trust it anymore. And so the machine learning algorithm, it is more sensitive, but where it really has value is in its specificity. And so it's really reducing that false alarm rate by 50%. And so hopefully people will feel a little bit more confident acting on the results, because they won't think that it's just a false alarm.
There weren't any other failures in the chain of care then that were leading to this? Were these BPAs out of the box from Epic, or were they?
No, these are ones that we developed.
Okay, but they're still too sensitive. Is that right?
Well, I think they're adequately sensitive. They're just not specific at all.
Right.
Yeah.
So, okay. So your premise was that like really the primary problem here was just people not responding adequately to.
Right. That's why they were dismissing.
And everything else seemed to be in order.
Yeah. I mean, there were other parts of the management that they're helping to fix in terms of how they deliver fluids and how they do blood pressure support. And that, with the new management tool, they're able to see continuous tracings of those key variables so that they can understand, their mean systolic's been 80 for the last 12 hours. Hopefully you're going to do something about that.
Yeah.
But for the tool itself, it was mostly around the specificity.
Okay.
Yeah.
What was your strategy to loop in all of the relevant stakeholders in co-production and carve out meaningful amounts of time for them to be able to be kept up to date on your design? Like, how did you end up scheduling the logistics for that?
That's a great question. And I would say that we have Jessica Chow, who's our program lead director, and she helped found the CIC, and now she's working with us on a contract basis. But basically, the way that you get them involved with co-production is you get their commitment and you work with their schedule, and you don't over schedule them. So we know that with the executive leaders, they're going to get quarterly report outs once they've committed to the program, and that's their chance to give feedback. With the clinical care operations leadership, once we're in working with that unit or those units, they are critical for giving Jan and others entree to the unit. And so a lot of their role is about verifying and validating that the staff need to be working with us and giving us good information. And then also helping us with the feasibility. They understand how the units operate. And so if we're proposing things that, oh my gosh, with delirium, there were just a lot of different ways to help reduce delirium prevention. there's no way the nurse could do all this in a single shift. And so we had to bring in volunteer services. We had to assign some things to social work. But yeah, we try to level load the amount of work they're doing based on, or the engagement with those folks based upon what they can give us, basically. But the other key thing we do is, at least with Caring Wisely for sure, is we put them on the hook for success, because if they select the projects, then they want to see them succeed. And so we know that we can come to them when we need to for problem solving if something's not going right. Let me just finish with one slide, because I know it's getting late. So we do have a resources slide that has the websites. So Caring Wisely, I think the call for proposals will come out in February or and that runs between February to April. Strategic innovation, that doesn't quite have a home yet. I put the CIC and the continuous improvement department up there, but if you have sort of a big audacious program or innovation that you think needs to be brought to the enterprise leadership, I'm happy to hear it out and represent, give you feedback and represent that until we get a better portal. We also have something called, we just got funded for a embedded scientist training and research center called eStar. This is from AHRQ or NIH. And we fund learning health system scholars for 1 year to participate in a program that is modeled after Caring Wisely. So you have a project, you're partnering with we have projects in the health system that are already curated and prioritized that you would just attach to. We give you $25,000 for supplies and resources, but you have to have your own protected time. So that's the kicker. So it works really well for clinical fellows because fellows are already in fellowship programs. It works well for something we call the non-ACGME medical educator fellowships. So those are also, basically if you're a physician, you can work part-time, 50% time, and then the other 50% time you can do training and research. And that 50% of clinical work covers your salary as a fellow. And then finally, Jan has a human-centered design course that she teaches with a colleague. It's a 10-week course, and I think they have virtual or no virtual. Oh, well, there you go, 100% virtual. So that's the end of our talk, and I'm happy to take more questions.
Well, first of all, let's. Thank you both. That was really, really valuable. We have recorded it, so you'll get a link sent to you. There's a lot to go through and review and learn from. Do we have any questions online? Okay.
Yeah, not yet.
Okay. Anybody else in the room want to ask a question in the group setting? Otherwise, we'll do some networking. Yeah.
Ralph, how easy or feasible is it to go from a local solution across to the UC? And making it a product is a different animal in itself, but have you been able to get it to the UCLA, Geffen School of, how's adoption been across the UCs?
So there's examples from the COVID work we did, and then there's examples from eConsult. So eConsult is probably the best example where we had the proof of concept here. And what was different about what they were doing at the General is that we designed ours for a fee-for-service setting. So we had payments for the e-consultants that previously were not happening. We proved the model. We got payers to pay for it because we showed them that it reduced their cost because people were no longer having to go in for the $300 in-person visit. They were getting a $50 e-consult for the same result, same price. So basically, there's an office called UC Health, and there's a medical director, David Rubin's the medical director. And when we pitched the idea to them, they gave us a grant to basically take it to the 5 UCs because they're all on Epic. And around the same time, Arista MD licensed the templates and set up their business to help other health systems, especially incarcerated, like the prison systems. And what was really ironic, a funny twist of fate, it was that about 5 years ago, we see an advertisement from Stanford that they're now offering, they're partnering with Arista MD to offer e-consults to their community providers as sort of a promotion. And little did they know that all the decision-making in those e-consults come from UCSF. But I would go to UC Health, and there was some good uptake, and we also ended up getting a a Centers for Medicaid and Medicaid CMMI. It's part of CMS. So we got an award from them to do this 16-site cluster randomized trial of the e-consult. Someone was talking about evidence that Medicare was not going to pay for these until they did a full demonstration program. So, but they gave us 10 million to do that. And it worked. I mean, it doesn't induce demand. It really does. See, the problem with e-consults is they think, oh, well, if you make it that easy, now they're just going to flood. They're just going to game the system and just do every curbside consult is going to turn into an e-consult. And that's just didn't happen. I think that's not how, I think in general, we just want to take care of patients and we're not going to game the system.
I thank everyone who stayed and participated, because you all had long work days, because you are either clinician innovators, scientist innovators, meaning you have another primary role, but your passion for innovation has kept you here late tonight. And I think we got well rewarded for that. So thank you very much. Stay tuned. I think September 13th is the next day. And just so you know, this was a lot of clinical focus tonight, but innovation in research is badly needed, even in your own processes, because I know some of you are in research laboratory setting, or even in education. So we talk about frontline innovators from clinical to research to education fields. So, but the principles that we heard here tonight, they matter across all of that. So thank you very much, both sides, audience and presenters.